thinking a little bit more specifically about the COMMANDS trial and really what it has taught us and done in the field, just to make sure that all of our listeners are aware, this is really a pivotal randomized phase 3 trial with the prior standard of care, which has been ESAs in these low-risk MDS patients who are transfusion dependent versus luspatercept. And the primary endpoint, the primary outcome measure is red cell transfusion independence for I can't remember if it was an 8 or 12-week period of time. I don't remember if either of you remember offhand.
Yeah, I believe it was 12 weeks
within the first 24 weeks of
with
the
an
trial,
additional higher bar of hemoglobin increase.
Yeah, so it's tough to hit that. And this was achieved by almost, 60% or so of patients who received luspatercept versus a little over 30% with EPO alpha. So, it really establishes a new first-line standard of care in a lot of ways. And then the question is there enough awareness about this? What do you do if somebody's already on EPO? And then, of course, you might think about using this therapy second line. But if you look at the second line data, there's a sense that maybe this therapy isn't as effective if you use it later. So do you want to make your first shot your best shot? How are we sequencing these therapies? And then imetelstat comes online too, which is a whole nother separate discussion.
Right.
Right. A lot of good things going on in MDS. That's why we're here to talk about it.
No, I think sequencing becomes a key issue, obviously. And, I think looking at the COMMANDS data, you mentioned the improvement in response rates. I think, when I think about the fact that luspatercept on that trial is being dosed, as is in the label, every 3 weeks versus the fact that they were dosing epoetin alpha on a weekly basis. My patients don't like to drive to come into my office either. The parking situation in northern New Jersey is really quite bad. So I think it's not very realistic to bring patients into the office on a weekly basis for epoetin alpha. So I think thinking about the reality of what I can achieve and also sort of quality of life aspects, that has also, I think, even in some of these RS negative patients where maybe response rates were a little more equivalent, thinking about the burden of treatment and the dosing schedule and also the duration of response has, really led me to, I think, kind of turn toward luspatercept as my general first-line therapy for lower risk patients.
Can you say a bit more about duration of response then from what we know from COMMANDS?
Yeah, so what we saw is that on average, patients treated with luspatercept had 2.5 years of response versus about 1.5 years for ESA-treated patients. So, to your point of kind of using your best therapy up front, I think also looking at duration of response helps us to kind of speak to that point as well.
Yeah. It's unfortunately still not long enough for those 5 to 8 or more years of survivorship on average with low-risk MDS. So we still need new and better therapies. But.
Yeah, I think, a big takeaway for me is that we really shouldn't settle for mediocrity. I think it gets into this idea of, in the beginning, first paper we talked about, right? The fact that so many people are kept on ESA without having benefit. They don't move on to a new therapy. And then if you look at, there's an interesting paper also recently presented about PROs in patients who, whether they got luspatercept or they got EPO, if they achieved an improvement in hemoglobin, the quality of life improved. And I think that this is one of the first studies to really, in a modern era with newer therapies, really show this tight correlation between trying to aim for closer to normal hemoglobin goals. And are we doing some patients a disservice by maybe keeping them at a hemoglobin of 8, even though, you're not needing frequent transfusions, but how much are we really improving that quality of life metric? I think we've often had difficulty in prior studies correlating just transfusion independence with quality of life, because that accounts for people who jump up to a hemoglobin of 11, but it also includes people who are stuck at like a hemoglobin of 8.2. And there's a lot of variable practice in who gets intervened upon and who doesn't. And now with a number of agents, I really view this as, we should be optimizing patient to patient. And so there's great data, sequencing. I think we still probably need some well-developed studies or at least retrospective data to understand sequencing patterns. But I think you've got 2 agents that are active, and whatever you do, you spoke about the duration of responses. even in the people who were on EPO who got responses, some of them really could have 1 year, 1.5 years of responses.
Yes.
It was just the chance of that, the percentage of people who got those long responses, and this being presented at this year's ASH, was much lower. And so you can get there, but if you start somebody on EPO and they're not getting that great response, you really should switch over. For my practice, that's been my big takeaway about where the field has moved. We now have a lot of agents. We really should be striving to get a better blood count for every patient that we see.